All right, welcome everyone. As ophthalmologists, you're dealing with this incredible complexity of the visual system day in and day out. And today we're going to zoom in on a structure that's just, absolutely fundamental to your practice. We're talking about the optic nerve.
Yes, exactly. The optic nerve. And we're going deep today. Really dissecting its anatomy, understanding how it works, and of course, what happens when things go wrong, when we see dysfunction.
That's right. We've pulled together, a wealth of information here to really unpack this. So we're talking everything from the vascular supply, right, like the literal fuel lines of the optic nerve.
Yeah, to the tests you're actually using, in your clinics, like VEP. That's a big one for assessing optic nerve health.
Totally. And then, getting into the nitty-gritty, the different ways we classify optic neuropathy, the different types of atrophy, the whole 9 yards.
The goal here is to really pull out those key points, the insights that can really refine your understanding. And, maybe even spark some ideas for your approach in the clinic.
Exactly. So let's kick things off with the anatomy. It's amazing how this relatively small structure, it's pretty tiny when you think about it, is just so crucial for sight. And I think a good place to start, especially when we're considering things like potential vascular problems, is that ophthalmic artery.
Right, the origin.
Yeah.
That ophthalmic artery comes straight off the internal carotid. And what's interesting is it actually runs right alongside the optic nerve,
Yeah.
all within that bony optic canal.
All right, side by side. Okay, so then we move a bit further back, and what's happening about 8 to 12 millimeters behind the globe.
That's where you get this crucial branching. The central retinal artery, it's basically like a continuation of that ophthalmic. It actually dives right into the nerve itself.
Wow.
And as you know, that's the main blood supply for those inner layers of the retina.
Right. So essentially, you have this highway coming in, the ophthalmic artery, and then branching off to provide that very specific blood supply for those inner retinal layers. Now, when we zoom in on the optic nerve head itself, that very front part that you're looking at during an exam, we've got this intricate network.
Yeah, the circle of Zinhaller.
The circle of Zinhaller. And this is where I think things get really interesting when we're thinking about potential areas of vulnerability, right? Because this circle, it's not just supplied by one vessel, it's getting blood from multiple contributors.
Exactly. You've got, 4, maybe 5 long posterior ciliary arteries feeding into it. But then you also have branches from the choroid itself and even, those tiny vessels of the pile network on the surface of the nerve.
Right. So this multi-source supply, it's vital. It's like a safety net in some ways.
It is. But it also means that different ischemic events, depending on which vessel is affected, they can manifest in different ways. Clinically, that's huge.
Absolutely. Thinking about AION, for example, anterior ischemic optic neuropathy.
Right. The fact that the optic nerve head gets blood from all these places,
Yeah.
that's a major factor in how susceptible it is to those ischemic events.
Right. And whether it's an AION, versus, I'm trying to think, like a ciliary retinal artery occlusion.
Exactly. So that anatomy, knowing where the blood is coming from, that can really change how things present for you. It's a key takeaway for sure.
Okay. So now, shifting gears a little bit, let's talk about the structure of the nerve itself. We're talking about, what, roughly 1.2 million nerve fibers?
Yeah, about that. Afferent fibers, all coming from those retinal ganglion cells carrying that visual information.
Unbelievable. And almost a third of those are devoted to just that central 5 degrees of vision. It's like, a tiny little spot, but so critical for sharp vision, right?
It is. Think about it. A third of all those fibers, just for that tiny area. That's why even small bits of damage to the nerve can really affect acuity.
Right. That makes total sense. And then within the nerve itself, those fibers, they're not just all jumbled up, right?
No, they're organized. They're bundled up into about 600 of these bundles, thanks to those fibrous septae coming in from the pia mater.
Right. So there's actual structure even within the nerve itself. And of course, we got to talk about the surrounding layers too. So we've got the pia mater, which is super vascular. It's hugging the nerve tissue.
Right. And then on the outside, you've got that tougher outer sheath. That's the arachnoid and the dura fused together.
Right. And that outer sheath for you guys, I'm thinking about procedures like optic nerve sheath fenestration.
Oh, absolutely. That continuity with the sclera, that's key for those procedures.
Totally. And then, of course, we have to remember that subarachnoid space around the nerve.
Oh, yeah. That's continuous with the cerebral subarachnoid space filled with CSF. So that connection is important when you're thinking about how things can spread, pathologically. Or even just the effects of high intracranial pressure.
Right, it's all connected. Okay. And to really appreciate the optic nerve's journey anatomically, we break it down into 4 segments. And each one has, its own quirks, its own potential weaknesses, I guess you could say. So first up, the intraocular segment. That's, what we call the optic nerve head, the optic disc.
Yeah, the part you see, it's short, only about a millimeter deep, maybe 1.5 millimeters across vertically. Yeah. But it's your window into the health of those fibers.
Right, that's what you're assessing. All right, next up, we head back, and we've got the intraorbital segment. This is the longest stretch.
Yeah, much longer. 25 to 30 millimeters. From the back of the eye to the optic foramen. And it gets thicker there, too, about 3-4 millimeters in diameter because of myelination.
Right, myelin, the fatty insulation. And at the orbital apex, the very tip of the orbit, the nerve is surrounded by the annulus of Zinn.
Which is, the common origin of the 4 rectus muscles.
Okay. And then it gets even more interesting. We've got the intracanalicular segment.
As it's passing through the bony canal, this one's shorter, about 6 millimeters. But the duramater there, it actually fuses with the bone, the periosteum. So the nerve is really fixed in place.
Wow, that's a tight squeeze.
It is. So you can imagine any swelling there can lead to compression really quickly.
Right, because it can't really move. And finally, we have the intracranial segment. This one's a bit variable in length.
Yeah, anywhere from 5 to 16 millimeters, 10 is about average.
Okay. And clinically, what's important here is that this section is vulnerable to compression from those nearby structures in the brain.
Right. Things like pituitary adenomas, aneurysms, especially if that segment's on the longer side.
So it's really a fascinating journey, isn't it, from start to finish? Okay, now let's switch gears again and talk about a really key tool you use to evaluate optic nerve function. I'm talking about visual evoked potentials, VEP.
Yeah, VEP. The idea behind it is actually pretty elegant. You're basically recording the electrical activity in the visual cortex in response to stimulating the retina.
Right, so you're looking at how the brain is reacting to those visual signals. And in ophthalmology, the uses are pretty broad, right?
Oh, absolutely. Monitoring visual pathways in babies, that's a big one. And then investigating optic neuropathies, especially the demyelinating kind.
Right, so it's not just about detecting problems, it's also about understanding the type of problem.
Exactly. And, it can also tell you about how well that macular pathway is functioning.
Yeah.
And even help you figure out if vision loss is, truly organic or maybe not.
Okay, so walk me through the technique itself.
Sure. You present a visual stimulus, something controlled. It could be a flash of light, what we call flash VEP. But usually it's this black and white checkerboard pattern that flips back and forth. That's pattern VEP. And to make sure the recording's good, you record multiple responses and average them out.
Okay. And then when you're looking at the results, what are the key things you're analyzing?
So the 2 main things are latency. That's the time delay between the stimulus and the brain's response. And then amplitude, that's basically how strong that response is. So with optic neuropathy, a lot of times you see that latency gets longer, the signal's taking longer to get through.
Right, like a slowdown on the highway.
Yeah, exactly. And often the amplitude drops too. The signal gets weaker.
Makes sense. Now, what about threshold VEP? How does that help with picking up on more subtle dysfunction?
So for threshold VEP, you change the size of those checks in the checkerboard. What you're doing is testing different spatial frequencies. And sometimes, in some optic neuropathies, the responses to those smaller checks, which really stimulate those central pathways, they might be abnormal earlier on compared to the larger checks.
Ah, so it's like a more sensitive test in a way.
Exactly. It can pick up on those subtle changes.
Really interesting. Okay, let's talk about the signs of optic nerve dysfunction that you're actually looking for in the clinic during an exam. Obviously, reduced visual acuity, that's a big one, right? Both near and far. But that's not always specific to the optic nerve.
No, it's not a slam dunk. Acuity can be pretty good, especially early on, or if only a portion of the nerve is affected.
Right, so you need to look for other clues.
Exactly. And one of the best signs for an afferent pathway problem, which includes the optic nerve, is the RAPD, the relative afferent pupillary defect.
Ah, the RAPD. So remind me, how does that work again?
So imagine, each eye has its own dimmer switch for the pupil.
Okay.
And with an RAPD, the affected eye's dimmer, it's not working as well when light hits it directly compared to when the light swings over from the good eye.
Right. So the pupil of that affected eye, it actually dilates a bit when you swing the light over from the healthy eye.
Exactly. It's like the signal isn't getting through as strongly. That's a key finding at the bedside.
Absolutely. And then there's dyschromatopsia, right? Color vision problems.
Yeah, and with optic nerve disease, it usually affects red-green vision. A quick way to check this in the office, it's even highlighted in our source materials, a tip is just have the patient compare how bright a red object looks to each eye separately. Or you can use the Ishihara plates, of course.
Right, right. And something else I've noticed, patients sometimes complain of this diminished brightness sensitivity in one eye.
Oh yeah, even after their acuity has recovered, say after optic neuritis.
Exactly. It's subtle, but I think it's an important sign that something's not quite right.
It is, it is.
Mm.
And it's one of those things they might not even mention unless you specifically ask.
Absolutely. And then there's contrast sensitivity, too.
Right. Even if the Snellen acuity is good, poor contrast can point to a problem with the optic nerve.
Okay. Now, let's talk about visual field defects. I mean, this is where things get really interesting because the pattern of that field loss, it can tell you so much about what's going on with the nerve.
Absolutely. You see all sorts of patterns. You might get an overall depression of the central field,
Yeah.
or you might see more localized defects, like a central scotoma right in the middle of their vision,
Right.
or a centrocecal scotoma,
Yeah.
which hits both the central point and the blind spot.
Okay.
And then you've got those arcuate nerve fiber bundle defects following that arc shape, and altitudinal defects respecting the horizontal meridian.
So many patterns. It's like each one is telling a different story.
It is. And it's like a puzzle. You put the pieces together to figure out what's causing it.
Absolutely. So, for example, the text mentions that you often see central scotomas with demyelination.
Right. Demyelination. Toxic or nutritional optic neuropathies, too. And Leber's hereditary optic neuropathy.
Okay.
Oh, and compression of the optic nerve.
Right. And if you see an enlarged blind spot.
That could mean papilledema or maybe some kind of congenital anomaly of the optic disc.
Okay. And then those defects that follow the horizontal meridian, those altitudinal defects.
Those are often seen with AION.
Right.
Glaucoma, too, though the mechanism is different there. And disc drusen.
Okay.
And finally, those upper temporal defects that don't quite respect the vertical, those can sometimes be a clue to a tilted optic disc.
It really is amazing. It's like a map, a topographical map of the damage, and it can really help you narrow down the possibilities.
Oh, absolutely. It's a crucial part of the diagnostic process.
Okay, so let's move on to how we actually classify optic neuropathy based on the cause. And I got to say, it's a pretty long list, which just goes to show how many things can affect the optic nerve.
Yeah, it does. But let's break it down systematically. So first up, we've got the inflammatory conditions.
Okay.
This is where you have things like optic neuritis. And there are all sorts of types, demyelinating, parainfectious, infectious, non-infectious. And then there's neuroretinitis, which is its own thing.
Right, right. And of course, glaucoma is a huge category in its own right.
Absolutely.
Yeah.
A huge one. But, we've got a whole separate discussion dedicated to that in Chapter 11.
Exactly, so we won't dive too deep into that here. Okay, so moving on. We've got the ischemic optic neuropathies.
Right. So here you have things like AION, both the non-arteritic and arteritic forms. Then there's posterior ischemic optic neuropathy and diabetic papillopathy. Each one has its own, presentation, its own risk factors, its own mechanisms.
Right, so you really have to be able to differentiate between them.
Absolutely.
Okay. What else we got?
Well, we can't forget about hereditary factors.
Right.
Leber's hereditary optic neuropathy, that's a classic. And then there are a bunch of other hereditary optic neuropathies that can present in different ways.
Okay.
And then you have the nutritional and toxic optic neuropathies. That's a whole group of conditions that we cover in more detail in Chapter 21.
Right, right.
And of course, you have papilledema. That's the swelling of the optic disc due to increased intracranial pressure.
Right, a crucial one to recognize.
Absolutely.
Mm.
And then there's traumatic optic neuropathy, which we discuss in Chapter 22. That's from a direct or indirect injury to the nerve. And then compression, which we talked about before, can be from a lesion in the brain or even in the orbit itself.
Right.
And finally, we have the infiltrative optic neuropathies. This could be from inflammation like sarcoidosis, or from a tumor growing into the nerve, or even from an infection.
Wow, it's quite a list, isn't it?
It is. It really is. So the challenge is really, taking all the information you have, the patient's history, your exam findings, any tests you've done,
Yeah.
and putting it all together to figure out the specific cause.
Right. Okay, so now let's talk about the end stage, I guess you could say, of many of these insults to the optic nerve, and that's optic atrophy.
Right. Optic atrophy. That's when you have those axons, those nerve fibers that connect the retina to the lateral geniculate nucleus. They're actually lost. They're gone.
Right. So it's irreversible.
It is. And that means there's permanent damage to vision. And you see changes in the optic nerve head itself when you look in the eye.
Okay. And broadly, how do we classify optic atrophy?
So we break it down based on, what happened before and how it looks. So you've got primary, secondary, consecutive, and of course, glaucomatous.
Okay, let's start with primary. What makes that unique?
So primary optic atrophy, it happens without any swelling of the optic nerve head beforehand.
Okay.
And it can come from a lesion anywhere along the pathway after the retina,
Hmm.
from the retrolaminar optic nerve all the way back to the lateral geniculate body.
Okay.
Now remember that lesions before the chiasm, they usually cause atrophy on just one side. But if it's at the chiasm or further back, it'll be both sides.
Right, that makes sense. So what are you seeing in the eye with primary atrophy?
Well, classically, it's this flat white disc with
Yeah.
really sharp margins. It's in figure 19.7a if you want to see a picture. You'll
Okay.
also see fewer small vessels on the disc. And those peripapillary arterioles, they get thinner. And the nerve fiber layer gets thinner too.
Okay.
And the atrophy itself, it can be all over the disc, what we call diffuse, or it can be just in one sector, depending on the cause and where the lesion is.
Right, right. Now, the text mentions temporal pallor specifically. What does that mean?
So temporal pallor, that's when the temporal side of the disc looks whiter, and it usually means the papillomacular bundle is affected. Those are the fibers responsible for central vision and color vision.
Okay.
You often see this after demyelinating optic neuritis.
Right. And what about band atrophy?
Band atrophy, that's when both the nasal and temporal sides of the disc are pale. And that suggests a lesion at the chiasm, or the optic tract, affecting the fibers coming in from those directions.
Okay. So what are some of the big causes of primary atrophy that we should be thinking about?
Well, optic neuritis is a big one.
All right.
Compression of the nerve from a tumor or aneurysm. Figure 19.7a actually shows those shunt vessels on the disc from compression,
Okay.
hereditary optic neuropathies, those toxic and nutritional neuropathies, which, remember, can start with temporal pallor because of those papillomacular fibers, and trauma, of course.
Right. Okay, so let's move on to secondary optic atrophy. What's the difference here?
So secondary atrophy, the key is that there's always swelling of the optic nerve head first,
Okay.
what we call papilledema or papillitis. And the way the disc looks afterwards, well, it can vary a bit depending on the cause and how long the swelling lasted.
Okay, so are there any sort of general features of secondary atrophy?
Generally, the disc will be a bit raised, maybe slightly, maybe moderately,
Mm.
and it'll look white or grayish with blurry margins. That blurriness is often from gliosis. That's when glial cells proliferate after the swelling.
Okay.
You might also see that the lamina cribrosa is obscured, and there might be fewer small vessels on the disc. And sometimes you see those peripapillary folds, those patent lines, especially on the temporal side. Figure 19.7c shows that.
Okay.
And then there could be arteriolar sheathing and venous tortuosity.
Okay, so quite a few things to look for. And what are the main things that cause secondary atrophy?
Well, if papilledema goes on for a long time, that's a major cause. Then you have AION, both the arteritic and non-arteritic types,
Yeah.
and severe or prolonged papillitis. Oh, and some people actually classify the atrophy that happens after really bad intraocular inflammation as consecutive atrophy, not secondary.
Yeah.
Just a different way of thinking about it.
Interesting. Okay, so then let's talk about consecutive atrophy. What's the mechanism there?
So consecutive atrophy happens because of a problem in the inner retina itself or its blood supply. And usually you can actually see the retinal problem when you examine the eye.
Okay.
So things like, scars from laser treatment, those pigment changes you see in retinitis pigmentosa, or a past central retinal artery occlusion.
Okay. And how does the disc look with consecutive atrophy?
It often looks kind of waxy or pale,
Yeah.
but the overall structure is usually pretty well preserved.
Yeah.
The margins are still pretty distinct.
Yeah.
Figure 19.7d shows that.
Okay. And then finally, we have glaucomatous optic atrophy.
Right. And as you know, the text sends us back to chapter 11 for that.
Exactly, because as ophthalmologists, you're all very familiar with what happens in glaucoma, with that cupping of the optic disc and the loss of nerve fibers.
Exactly. But it's important to remember that, optic atrophy, it's kind of the final result in a lot of different optic nerve problems. But the underlying cause and how it looks can vary a lot. So you really need to be thorough in your exam and think about everything to make the right diagnosis.
Absolutely. Well, this has been a fascinating deep dive, I've got to say.
It has.
We've covered a lot of ground, from the anatomy and blood supply of the optic nerve to all the different ways it can go wrong and lead to neuropathy and atrophy.
And hopefully, by going through all of this, the anatomy, the tests like VEP, the subtle signs to look for, and how we classify all these conditions, you've got a better grasp on how to approach these problems in your practice.
I think so too. So, to leave you with a final thought, something to chew on, we talked about how complex that blood supply to the optic nerve head is, with all those different sources. And I'm wondering, how might those little differences in each patient's anatomy right there at the nerve head, how might that affect how susceptible they are to ischemic events? Things like non-arteritic AION.
That's a great question. It's something to think about, as you're evaluating and treating patients with these conditions.
Absolutely.
All right. Well, thanks for joining us for another deep dive.
It's been a pleasure.
And we'll see you next time. See you then.